Before getting into some of the biomechanics and anatomy of the rotator cuff, let's first look at sort of a definition of what a massive cuff tear is. And certainly the definition is a little bit nebulous in a lot of the literature. So a lot of studies talk about anatomical definitions, and these vary from things such as the diameter of the tear or a product of the two dimensions of the tear. However, these are very dependent on, of course, the size of the patient and the size of the cuff itself. And they give no indication of which tendons are involved. And certainly some other definitions look at how many tendons are involved rather than the size. So, a lot of that has implications for this sort of force balancing and force coupling that they the article states that there's a prevalence of 10 to 40% of rotator cuff tears would fall into the massive tear category. But more of these, so about 28% of all rotator cuff tears would be seen as a massive tear, and the remaining 20% would be anterosuperior tears. A massive tear does not mean that a tear is irreparable. Some of the factors that come into play there are the acuity of the tear, whether there's been superior migration of the humeral head, evident on X-ray, narrow or absent acromiohumeral interval, and greater than or equal to 50% of fatty infiltration. We look first at the biomechanics, so some anatomy for the medical students here, and I apologise, this is in German. So this is looking at a right humerus from laterally. So we've got anterior on the right-hand side of the screen, and this quite well demonstrates you've got supraspinatus coming in and inserting into the more posterior of the facet, and then infraspinatus coming up, teres minor, and then subscapularis coming from the subscapular fossa around, inserting into the lesser tubercle, and hence being responsible for internal rotation. Importantly here, you've got the coraco. Which one? Look, I would have probably said this is more supraspinatus here.
Yeah. I mean, I don't understand that.
No, let's ignore.
Maybe because infraspinatus is usually.
Sorry, this is more for the picture rather than the labels. So ignore the labels.
The bottom one is teres minor, and that's infraspinatus, and that's supraspinatus.
Yeah, okay. That makes more sense. Sorry about that. And the rotator cuff muscles function as primary dynamic stabilizers along with the deltoid muscle to maintain the concentric reduction during rotation of the humeral head within the glenoid fossa. And this is looked at in terms of force couples. So you've got a balanced coronal force couple in the inferior part of the cuff as well as deltoid, as well as a balanced transverse force couple, meaning the muscles responsible for essentially internal rotation and those responsible for external rotation acting against one another. Massive tears disrupt this force couple to varying degrees depending on which parts of which tendon are disrupted, and ultimately compromise the function that isn't responsible for normal mechanical sort of function of the joint. Tears that involve supraspinatus and the superior half of infraspinatus, so a posterior-superior tear, tearing this posterior-superior section here, may not impair function as often a balanced force couple is maintained, which gives way to the argument for classifying these based on function rather than on pure diameter of a tear. So looking at history and examination, patients classically give a history with massive cuff tears. They do actually get pain at night. as well as impairment and pain during ADLs, with varying degrees of weakness and loss of range of motion. On examination, there may be visible atrophy, particularly of supraspinatus and infraspinatus. In a posterior superior cuff disruption, in both posterior superior and anterior superior, you get decreased abduction, of course, decreased forward flexion, decreased active external rotation. With posterior superior tear, you can get a positive hornblower sign. And with anterior superior tears, you often get a positive belly press or lift-off test because you've got that impairment rotation because of subscaps involvement. Looking at imaging, so on X-ray with massive cuff tears, you often see this decreased acromiohumeral distance or superior migration of the humeral head. I know I've been referred a few patients by emergency querying shoulder dislocation when in fact they just have a massive cuff tear, humerus sitting quite superior. CT does have a limited role in assessing muscle atrophy and fatty infiltration. Ultrasound, on one hand, is very operator dependent, affecting the quality and diagnostic utility of the images. But on the other hand, can be dynamic, and you can actually perform scans with symptom reproduction, and is more useful in the presence of particularly recently implanted material, be it metal plates or otherwise, where MR might have too much artifact. MR has been described as 100% sensitive for rotator cuff tears, which I found an interesting statement. But is incredibly accurate in assessing size, retraction, and particularly fatty infiltration. Moving on to treatment options, and we'll go through the whole spectrum of treatment options available fairly broadly without getting into too much. But of note, you have to realise that there is no randomised controlled trials comparing the various surgical options. Most evidence is level 2 or 3, if that, for any of the interventions. This article specifically seems to quote a number of papers for all modalities of treatment that only have between series. And of course, this is because there's great heterogeneity with regards to the severity of cuff tears, the definition, indeed, of how you actually define a massive cuff tear, the tissue quality and fatty infiltration of the tissues, symptoms, and what the patient's expectations of a We begin with looking at non-operative management. So the rationale for non-operative management is that many interventions actually do have a high recurrence rate when you're dealing with massive rotator cuff tears, and you can achieve good motion and function in a lot of these patients. In cadavers, they note that you can actually have preserved abduction even in the presence of a massive cuff tear, but you require much higher forces in deltoid and what is left of the cuff. Some sources do actually talk about a rehabilitation being of use as re-educating the deltoid, so that you get a somewhat superiorization of the humeral head, and it hinges on within underneath. And in 50 to 85% of newly diagnosed cuff tear patients, you will get some degree of improvement with regards to pain. That being said, symptom duration correlates very closely with long-term success. So the longer the symptoms persist during non-operative management, the more likely non-operative management is to not be successful. As I said, there is very limited evidence. And these three things are also considered poor prognostic indicators. Severe OA, decrease in acromiohumeral distance, and fatty infiltration of the muscle bellies. So the first operative intervention is your debridement and subacromial decompression. I've left the sort of chicken and egg discussion around But this intervention has shown satisfactory short-term outcomes and is particularly useful in elderly, very low demand patients with poor tissues where a repair is likely to fail. If their primary complaint is pain, but they do have a reasonably preserved active range of motion for what they would like to do with the arm, and an intact force couple. You do need to ensure that the CA ligament is preserved, because this is a static stabilizer against anterosuperior escape of the humeral head, which can be quite a problem. And there's mixed results with no clear answer out of the arthroscopic versus open debridement and decompression. They also talk about shaving or resculpting of the humeral tubercle, greater tubercle rather, which is in a sense essentially a reverse decompression of the subacromial space. Biceps tenotomy is also discussed. The function of the tendon of the long head of biceps is controversial in the mechanics of the shoulder, particularly in the as to whether it's a dynamic or a static stabilizer of the humeral head. Recent studies showing it is potentially more simply a static stabilizer and is certainly considered by a lot of surgeons as a source of pain and discomfort for patients. And a tenotomy has been shown in, again, limited case series, but case series nevertheless to be quite useful in symptom management. Moving on to partial repair, again, which a lot of surgeons and some of the literature suggests can be of use. Complete closure of these massive defects can be less important than just simply restoration of the stable force couple that we spoke about, and hence achieving a more anatomical fulcrum of the glenohumeral joint. Repair of infraspinatus can improve external rotation and function, even more so than supraspinatus, in which case it will be used to repair infraspinatus, even if supraspinatus was irreparable. Margin convergent sutures improve the mechanical advantage, and you can achieve significant improvements in abduction and forward flexion in repairing the entire cuff. Complete repair can often be achievable, and certainly this article notes that a lot of tears that may be in the first instance considered irreparable, with adequate mobilization and bringing forward of the tendons, you can actually perform a complete repair, but it's difficult to achieve a long-term healing with structural integrity, particularly when one of the studies reported by this paper reports 17 out of 18 re-tears within 36 months. With regards to technique, one needs to address tendon loss, retraction and adhesions of the tendon, and scarring involved. There needs to be a release of these adhesions, excision of the bursa to free up space for the repair, as well as for ongoing scarring and adhesions. And Burkhardt described that 90% of these tears were primarily repairable if you did manage all these adhesions and scarring considerations. It's also been considered useful to do to perform releases, particularly between supraspinatus and infraspinatus, as well as anteriorly. Optimal technique and anchor configuration has been a point of controversy. The ongoing debate about double versus single row repair seems to be leaning far more in favour of double row repair at this point. The arguments being that you get greater bone and tendon contact, a larger surface area, but on the other hand, you may be arguably over-tensioning the tendons by bringing them laterally. Looking at outcomes, there are a couple of studies considered quite prominent, and even there you've got a 37% re-rupture rate after a few years. Female sex and symptoms greater than 34 months in the initial setting being predictive of an inferior outcome. And re-rupture is closely linked, probably obviously, with the size of the defect and the extent of the fatty infiltration of the muscles involved. Looking at fatty infiltration, obviously as the muscles atrophy and of no use, the fat actually infiltrates the muscle fibers. Goutelier actually described this classification initially based on CT scanning, but that's been transitioned somewhat to an MR setting. And there's certainly a very good correlation between fatty infiltration and overall shoulder function. The suprascapular nerve is also a consideration. So remember, you've got the suprascapular nerve coming from the upper trunk of the brachial plexus, coming under the suprascapular ligament in the suprascapular notch superiorly, innervating supraspinatus, then swinging around the spinoglenoid notch to innervate infraspinatus. Both of those points being points at which you can get impingement. And looking at the mechanics of it, if you get when you get retraction of these muscles in the context of a complete tear of their tendon, they contraction the nerve and essentially cause a neuropathy. Interestingly, and something that I wasn't aware of, is that a lot of papers actually show that repair of the tendons, you do get significant recovery of this neuropathy, which has been proven on electrodiagnostic studies. I'm not sure. Moving on to some more complex methods of repair. There are a few studies looking at scaffolds and tissue augmentation. Neither of these look particularly appealing. They talk about dermis-based patches, which do improve constant scores, but you don't get reversal of any atrophy or fatty infiltration. And the few studies using small intestine submucosal patches also have very unfavourable. Several tendon transfers have been suggested depending on which part of the cuff is involved. Ideal candidates for these are young people with good chances of healing, good quality tissues, and who have high functional demands. And of course, with no pre-existent osteoarthritis of the. They are extensive operations and do require a significant rehabilitation period. For posterior or posterior superior tears, latissimus dorsi transfers are described, as shown in the diagram there. Even they have a 27% re-rupture rate, and it's important to look at the success of both these procedures is much poorer when they are revision procedures, if another intervention has. For subscapularis tears, they talk about the sternal head of pec major being brought forward to regain internal rotation. Moving on to patients who already have degenerative glenohumeral joints with symptomatic rotator cuff pathology, hemiarthroplasty is suggested as an option. Success of this is related to an intact subscapularis and preserved axial force coupling dynamics. And that static anterosuperior escape we spoke about with the the CA ligament rather, disruption is a contraindication. Clinical outcomes of this are mixed. Moving on to our reverse shoulder arthroplasty. Standard shoulder replacement is contraindicated in the context of these big rotator cuff tears because you've disrupted the mechanics of the fulcrum of the glenohumeral joint. You actually subject a classical glenoid component to a lot of shear forces, and this ultimately causes problems with bone structure. Reverse shoulder arthroplasty, and I should have put a picture in here, medializes the center of rotation, hence tensioning the deltoid by essentially lengthening the arm and allowing a greater lever. These have fairly good short-term results, but are associated with significant complication rates. And again, if these are revision or salvage procedures after performed, the results are far poorer. So as an overview, what to take away from this article and this sort of topic, that these massive cuff tears do cause debilitating shoulder pain and do constitute a fairly significant portion of cuff tears in the elderly. management options really do need to be looked at in the context of the expectations of the patient, the functional goals of the patient, and their biology and capacity for healing. And these operative repairs by any method can be technically difficult and do have a high rate of occurrence either in some of the larger and more successful studies. Specifically for partial and complete repairs, they advocate double row over single row currently, whether it be arthroscopic or open. And as soon as you're getting a degenerative joint or arthritic changes, the indications are more for management with a prosthetic.